Good morning. Okay, I'm good. We've been sitting for a while. I'll invite everybody to quickly stand up if you need a quick break. This is what a mentor of mine called the power pose. Try to hold it for about 8 to 10 seconds and your blood pressure will come down. Okay, good. This is going to be a little bit more interactive. My name is Ben Aiken. I'm a family physician and DPC doc with a practice called Avenu Health in Asheville, North Carolina. And I have the great privilege of being up on this stage with these outliers that we all want to learn from, including me. So we're going to set the stage just by a couple intro. Everybody's going to kind of self-intro. If you guys could give us your name of practice, where you're located, when you opened, a little bit of data on your growth, how many patients you started with, how you did that. We'll start there. I'll plan to ask a couple questions at that point, and then hopefully about the last half of this, we'll shift it out to you all. We'll have a couple mics that we can pass around, so if you've got some questions that are ruminating, write them down, and then maybe you can raise hands and we'll give you a mic and make it interactive. Okay, with that.
Hi, my name is Jason Larsen. I have a practice, Assurance Healthcare and Counseling Center in Yakima, Washington. We're in central Washington State. I opened alongside there are three of us, all family. So my father-in-law is the physician, I'm the business end, and then my sister-in-law is actually our mental health counselor. We opened in January of 2014, 100% DPC practice. We started day one with around 100 members, 100 to 150, somewhere in there. We were a little bit lucky in that my father-in-law wrote his contract at his previous job, so he actually owned all his patients' panels, so we sent out about 2,500, 3,000 letters to those patients. That's how we got that initial 150, and then some more trickled in after that. I think the other question was growth. I think our growth in the first couple years, we would average around 30 to 50 a month with some other spikes with employers or some other things that we did, so.
My name is Becky McGilligan. I'm an internist in Cincinnati, Ohio. With my husband, who is our computer engineer and runs the business side of the practice, opened McGilligan MD March 2018. We opened after a 4-month pre-registration with just under 300 patients. And by September, so 6 months later, I was at my goal of 500. I only see adults, and I do see some more complicated patients, so I did not really want to go much higher than that. I could probably get up to 600, but I want to do that very slowly. 2 months ago, we added a family physician who's been practicing for probably 20 years, and her hospital system did not send out letters of where she was going, so we're working on that. But she's about 40 patients right now, so I think that's it.
Hi, I'm Robert Lockwood, and our company is called Primary Health Partners. We're in the Oklahoma City metro area, and we have now 3 operating DPC clinics with a 4th one on the way in October. Dr. Kyle Rickner and I started this practice on January 1st, 2016. We actually started conceiving of the practice in October of 2014, so we took a very, very long time, talked to a lot of people out here, visited a lot of places, and finally made the jump. We both worked for a health system. We were both physician executives in that health system, and we started with 200 patients. Through divine intervention, we both worked at the same location, and through divine intervention, I don't think they knew what to do. They just left our numbers going and just put a message. Dr. Rickner and Dr. Lockwood have left. Here's their new number. So we were inundated with phone calls from patients, from med refill, you just name it. So we were able to market to them directly. The next month, Kyle reminded me, was it 500 after month 2, I believe? So we added about 300 patients in 2 months, and we're up to 500. And then at the end of the first year, we were about 1,100 or 1,000, 1,800 after year 2, 2,800 something after year 3. So we've had quite rapid growth, and it's been quite exciting.
It's really impressive. Yeah. Really impressive, all 3 of you. So in terms of just a starting question, it's actually 2 questions. One is if you could speak to 1 or 2 of the kind of most important things that you did really well as it relates to growth and starting your practices. and then one or two things that didn't go well?
So I think the thing that really went well for us was that I'm going to say, because of the fact that the panel sizes were smaller, as we were talking to our patients when we left, I think we did a really good job of marketing to them the necessity to sign up quickly. And so, and we had quite a lead time to do that, and so we started that process pretty early. Getting our website up and operational before our practice opened was really, really important. We tried to be very careful because we didn't want to violate any of our contractual obligations to our health system and have them come back on us. We were also very fortunate that we're a state where non-compete clauses really are kind of pointless to having a contract, so that really wasn't ever an issue. So I think that was one of the things we did really well. One of the things that didn't go as well as we had thought was when we opened, our building wasn't open. So we worked out of a 12 by 12 room and for about 3 weeks, and we did have a phone system so we could forward the calls to cell phones, and so that was helpful. But I can't even. It's hard to imagine there was 4 of us or 5 of us in that room. We had a surgeon and a physical therapist that loved what we were doing. So they said, "Hey, if the patient needs to be seen, just walk over here and see the patient." And so the patients would walk into the office to pick up scripts and things, and kind of look at us really funny, is like, "Is this a real operation or not?" That, and then also the other thing, Kyle and I were talking about this before I got up here, is if we really had thought it out in advance, we weren't really thinking about employers and going after employers when we first started. We were just thinking about getting started. We probably would have actually picked systems that we used, that we could use where we could get data out of them. And we didn't do that right off the bat. And so we had to do a transition in the middle of our practice, and that was extremely painful. Thank you, Tasha, by the way, for all the help with that.
So I was employed by a health system for 6.5 years before we opened our DPC practice, and my contract stated I did not have a no-compete as well. It was the only system in Cincinnati that does not give no-competes. And the other systems that I shopped around with there, they would have gotten rid of them, they told me, after I turned them down. So everything really is negotiable. But we had 6 months lead time. I put my notice in on the Game of Thrones finale of season 7 before it aired, because I needed to get it off my chest. And we got set to work with updating our website. I think that's definitely important, having that web presence. I had business cards, nice ones through Move, printed quickly, and I did hand those out to patients in the exam rooms. I spent a little extra time, like saying, having patients understand why I was leaving. And then my letter to my patients went out around Thanksgiving, so in November. We had opened pre-registration in November, and our first person to pre-register was 97 years old. Her daughter pre-registered her. My husband's like, "Yeah, we definitely need to opt you out of Medicare," because we were wondering how many of those people would come over. But the website, having print materials, we bought our first office condo and started renovating it, and we were almost at that spot. Like, literally, we were moving our furniture in the day before we opened. With adding a second physician, we've had to purchase another office condo space. We have 2 exam rooms currently, and during flu season, even with me, I realized it's kind of hard to navigate just 2 rooms if we're drawing labs in those rooms as well. So the office condo underneath us came for sale, and it's twice the square footage, so we're currently in reno year 2, and we're going to lease our current space to a urologist who's leaving a hospital system. I think the biggest thing that we struggled with initially, I mean, it is really hard to open as one doctor with that many patients, and so we wanted to make sure that we over-delivered and under-promised. So we wanted patients to get what they expected from our service. Cincinnati has a lot of concierge practices, and I think we did a really good job, because now we're poaching from the concierge practices basically too. Word of mouth is definitely our biggest lead source. I've probably spent $3 on Facebook ads. I think I did 1 just to see what it felt like. And now with the new doctor who's had like a 6-month time between when she worked for a major hospital system and is working with us. We're doing the every door direct mail. We just started it. She's getting out to the pavement, and when she goes to her kids' school events or when she goes to church, previous patients are asking her where she's at, and we're starting to get more calls there. Spring break's over, so next week her schedule's booked with meet and greets, which is wonderful. But the biggest thing that I think for new practices, you're always nervous about paying your bills and whether you'll fill or not. So if there's a new patient that comes in for a meet and greet and you all obviously get red flag signs, just trust your gut, because we didn't for, maybe like 3 people when we first opened. And that was painful, making the decision to cut the cord and realizing I'm not the right doctor for you, especially, drug seekers and whatnot. You don't want to cash for drugs to be an issue. But I think that sticking with your values and just over-deliver, show the patients you care. That's how we succeeded so well.
I'll start with our failures, because we all fail pretty big, I think, at times. The biggest failures we had were hiring the wrong people. We actually started out hiring a nurse. My father-in-law worked for 20 plus years in the normal system, traditional system, and he was very, very efficient, one of the top producers in the country with his hospital system. He said, I need a nurse, I need a nurse, I need a nurse. I said, okay, it's fine. So I went without a salary for a long time while we paid a nurse to join us. And it turned out we probably should have hired her for about 2 weeks to train him on how to administer vaccinations and do some things that doctors don't do normally, but then let her go. So we kind of kept her on a little too long. We realized that the experience is really important, the patient experience. And even the little thing like the doctor going out to the waiting room, wherever the patients are waiting, and being the one that welcomes the patient back is a huge thing, right? I'm not a physician, but I know that you can even look at the way that patient gets up out of the chair and start to do that. There's a 20-second walk on the way back where you can start engaging with the patient on the way back. We feel like that's really important for us. So with that, I feel like one thing we have done well has been that patient experience, trying to perfect that. Because really that's what it's about. It's about making patients happy. They're ultimately our customers, and we, even today, to this day, we still think about how can we make this patient experience better. The other thing that worked well for us in the very beginning was so we sent out that letter to our patients, and we invited them not only to join us in membership, but if they just wanted to try us out, we said, if you're a current patient of Dr. Edgerly, then come visit our clinic. If you're willing to pay us cash for that visit, you can try to reimburse your insurance. We're not going to do any insurance billing, but we'll bill you like a fee-for-service patient just so you can experience us. We gave them a time limit for that. I think for some people, we gave them about 6 months to come in and try us. And that gave them the experience of, oh, wait, I can actually call and get in that same day, and this is going to be the experience that I get. So that was good at getting people in the door with us, and also good for a little bit of cash flow in the beginning. The other thing that we did well is we figured out how to, with websites and everything, we figured out how to communicate what we do and what patients actually need. So instead of the call to action on anything, on our websites, on radio ads, on any marketing that we do, instead of the call to action being join us, become a member today, it would be learn more. So come to a seminar. That's something that we still do today is we host a lot of seminars where multiple people come, and I give between 45 minutes and an hour seminar where they can learn about us and how to wrap our DPC membership with whatever they have, whether that be a medical cost-sharing company like Sedera, a health-sharing ministry, their current insurance plan, their employer's insurance plan. We've become the experts at helping people understand how to navigate their entire healthcare plan, and that's really helped people trust us and end up joining us. So,
Great, all great insights. Robert, I think at a high level there are more or less kind of 3 segments of patient population. So direct-to-consumer approach, just individuals, consumers, the employer side, and then Medicare Advantage for some certain practices. You spoke to employers. I know you work with employers. Can you talk a little bit about how important that has been from a growth perspective? What's gone well, what's not?
I guess I'll start with the very first employer that we signed up had 20 employees. And we probably have, I don't know, Sharon, 20, 25 small employers now that have signed patients up. But that went really well. We kind of just did, a little meet and greet with them, took all the physicians out. Dr. Rickner and I were all the physicians at the time. And even our staff came out in the evening, and we just manually signed up the patients. So what was really cool about that is after a year, the owner of the company was a current patient and wanted to sign his patients up. Dr. Rickner asked him, how are we doing? You didn't offer any health benefits to your employees at all. This is the only health benefit they offered. So how's it going in your mind? And he said, great, you saved me 40% last year. And we're like, how? You were going from paying nothing to paying at the time, $59 a month for the patients. And he said, less absenteeism, more presenteeism, they're more productive, and turnover almost went to zero. And so that's one thing you need to do when you're going after small employers is you need to market yourself that way. A lot of you already know that, but if you're new, that's really important. The second thing about working with employers that was quite interesting, if we had known this in advance, this may be another thing that we didn't do quite as well. We would have started working with employers before we even opened the clinics. There is Erica's Bliss, as she has said, there's a long lead time to signing up a large employer. Even if they buy in totally to what you're doing and they get it, it's just a lot of work. It's going to take a lot of work. It's the reason why we have, someone that directs all of our operations now, and it's not me and Kyle anymore. It's more work than we can do. And so you got to be prepared for that if you're interested in going after the large employers. So we were fortunate. We just inked a deal with a big, gigantic Bankers Association group in Oklahoma. It's 4,500 lives. We're not going to take care of all of them. That'd be really scary. But the benefit plan is actually going to cover the cost of the DPC for the employees. So it's a little bit unique in that the plan itself is covering it. And then the employees will choose that option. So we're going to have some marketing we're going to have to do now to a whole bunch of different banks across the state of Oklahoma, and so that'll be challenging, and we're ready to get going. So literally in the next week or two is when this is all going to start. So maybe next year if you come back, I'll give you a bigger update on that. So
Good insights. We've got about 10 minutes, so I'm going to shift it out to the audience. I've got a list of questions I can keep going, but if there are questions from the audience, let's go there. Okay. There's a mic coming for you.
Hi. Question is for Rob. You mentioned that you had multiple clinics. I'm really curious if you could say a few words about how you fund those clinics. Are the doctors taking on the risk and the debt of getting a new clinic off the ground? Are you guys financing out of your revenue from your existing clinics, et cetera? Thank you.
So it's a little of all of that. So the thing that I guess probably scares most physicians from going into this practice is mitigating their risk, their income risk. They all want to do it. I mean, everyone here that's doing it gets calls on a routine basis, has friends, colleagues that want to come out and see what's going on, see that it's real, all of that. And so one of the things that was on our heart when we started our business was helping our colleagues that were burnout. Kyle and I both went to residency together, and our residency coordinator committed suicide last year. And I think that drove home. He actually had reached out to us prior to that, and I kept reaching back to him. I was kind of close to him, and had him out, all of those things for this kind of practice. I don't know that the particulars behind what happened and what was going on in his life, but that drove it home. And it wasn't just that, but that drove the stake home for us. It's like, we're definitely going to help other doctors now, whatever it takes. So we were very, very fortunate, very blessed. Two of our patients started a garage urologic DME company, grew it to $1 billion company, sold it, and had lots of money, kept begging basically us to invest in our company, and we were like, we don't need you, we're doing fine, you know. And then once we decided that we were going to make the jump and open multiple locations and try to help other physicians get started in this practice, help this movement get going, help businesses, small businesses, medium-sized businesses, and even large businesses across the state of Oklahoma, we realized we're going to have to do something different than we were doing. So, so they invested money, you know, and that's where some of that came. Some of it's funded through profits from Kyle and I's first clinic, and we started as well, and we moved forward. So all the physicians come in, and they, you know, we help them with a salary for a while, and they're happy about that. But they all take gigantic pay cuts to come do this. Anyone else?
Great. Other questions? One in the back.
Excuse me. I was wondering if you could share regarding integrating specialty care, if there's any barriers to getting care for your patients, if you're in an environment that's the specialists are primarily owned by hospital systems.
So I may be lucky, and the majority of my patients are insured. And coming from working in the system, I have great relationships with the specialists. So if I place a referral, I have no issues. In fact, I've actually found that I can get people in quicker because I have a network of cell phone numbers, and I'll just send a text, hey, Dr. So-and-so, call me when you get a chance. I got a patient for you. And they know that the patient's going to be well cared for, and I've already done the workup for them to need to come in. So that's been very helpful. I've had no issues. It's actually a lot easier to get care and get reports back now than it was when I was employed and seeing 35 people a day.
So we do have a fairly large patient population of uninsured patients. It's probably pushing up to around 30% now. They're very grateful for what we do, and of course some of those patients do need to be moved on and referred on to specialty care. In the state of Oklahoma, we have a very, very nice-sized free market. Most of our patients that see specialists, or the specialists themselves, do take insurance, but they also have cash pricing that's pretty reasonable for our patients to go see, and we can kind of let them know what things are going to cost as we refer them. And then on the other side of that note, I just don't refer as much as I used to. I mean, that's really it in a nutshell. Kyle, we had a medical student working, and they'd been there for, I don't know, a couple of months or a month. And at the end of the time, Dr. Rickner asked the student, is there any questions you have for me at all? And she sheepishly said, yeah, do you ever refer patients to specialists? It's like, well, yeah, but I guess we just haven't had the opportunity, so.
Once again, I have a lot of sick patients. So like there was a week last month where I had a sarcoma, a hepatocellular carcinoma, and then we thought someone had a plasma cell lymphoma from a biopsy that I had done, a shave that I thought was nothing, but she was worried about. That came back a wrong path read, thank goodness. But the workup's done, and they can get into specialists. Cincinnati is a bit unique in that our Academy of Medicine locally says that 70% of all-comer physicians are hospital employed. So that's taking into consideration neurosurgeons and dermatologists and radiologists, you know, whereas evidently most of the country it's closer to 50%. So if you think about it that way, 90 to 95% of primary care is employed in Cincinnati. So that was part of the growth issue too. Patients aren't happy with the hospital system primary care where you're just a cog in a wheel. And it's really easy to get patients there because of that. But all of the specialists are employed, all cardiologists. We have no cash pricing for echoes because of that.
Okay, I think we have time for one.
I've got a quick question.
Yes.
Turn this on. Yeah, so each of you has had really impressive growth. If you could pick one and only one thing that you would attribute your growth to, what would that be? And keep it snappy so that whoever that was can answer as well.
We offer time, and we have real people answering the phone, and patients feel a connection. They feel like they're part of the family. We actually care.
I would say that's basically it. I mean, our big growth came through word of mouth in the beginning. for sure. So it's how we treated the patients, and and it's very important your staff understands what you're doing. That is extremely important because they'll take a lot of phone calls for you.
And I think for us, rather than the time component, actually, it's more, for us, it's been more about access. So getting people access to their physician. So we don't necessarily promise long times, but we promise access, same-day service, and we've delivered on that.
One more thing. We haven't talked a lot about, we talked about websites, but social media is a big piece of this. And we didn't, a lot of the growth just came because of our city has a Yukon Happenings page. And we would just blow up about once a week on that, and then there would be just multiple responses back and forth. And our own patients were getting on there, responding back to the people that didn't believe it was true, telling them how much stuff costs, like how much a Z-Pak was, or how much a 90-day supply of metformin or lisinopril costs, and what it costs to get their labs done and stuff. And then occasionally one of our other physicians that we hired, Dr. Bourne, who was always on that page, she would help answer questions too. So there'd actually be a physician on there, as with it as well. So social media presence is really important.
We also have an office dog. Everybody loves the dog. It's being
We do
therapy
too
trained.
now.
You do? Isn't it
Yes.
wonderful? It really makes it feel like you're going to someone's house or you're part of the family.
Yeah.
There was another question.
We've got a minute left, so we'll take it quickly.
So as a new solo doc starting from residency, I'm doing everything myself, and I'm wondering, kind of when to hire the first staff member and what order to hire staff members.
We had said we were going to hire at 200 patients, and my husband started answering the phone immediately when my letter went out. He stopped taking computer contracts and answered the phone. That was key. If you let too long go between when you get that phone call, in our experience, and returning that call, you lose a lead because they're trying to get you for your access and that you're different. So if there's somebody that can do it on the side for you for a little bit, I think that would be very helpful. We have a medical assistant who does front and back. When it got to 400 patients, we hired a second because Brian's a computer engineer and he shouldn't be answering the phone about medical questions.
I would say know your strengths. Like, what are you good at and what can you do, but what do you need to outsource the most to other people and hire them first? And probably be willing to sacrifice those things, or sacrifice a little bit in the first 6, 9, 12 months of your practice in order to get the right people on board. That will help you grow exponentially if you just get the right people on board with you. So.
Okay. That wraps up this session. Thanks to him for bringing us together and this opportunity. Thanks to this panel. Awesome.